let Tracy introduce herself, but we're really happy and thrilled that Tracy Smith with the Illinois Public Health Association, she's one of our partners on this project, and she is going to be sharing information as far as how to really build that sustainable program incorporating community health workers into organizations. So I'm going to just kind of ping pong it over to you, Trey, and let you kind of frame it, schedule it, set it up however you choose to. So thank you.
Thanks, Rachel and Ava, and thanks everybody for joining. We know it's a busy week trying to get ready for the holiday and everything, and it's summer, so we all get it. So, along the way, it's a pretty small group. So, if you have questions, put them in the chat or raise your hand or just like come off mute and share. This is really what it's about. It's not that we're that large of a group that we can't do that. Correct, Ava? They can come off mute. Okay. I just wanted to make sure you had it set up so they could. So what we wanted to talk today, I know, I think it was just last week or the week before, you heard from Rachel and Jason, who started to share out some great information about billing, just general context. And so today, this session is about building sustainable community health worker programs in Illinois, looking at workforce alignment. There's so many levels to understand in this concept, and that's why we've broken them down into the way we're doing it. So today's session is really to look at how do you align those community health worker roles with Illinois payer expectations to identify proposed billable versus non-billable activities and to identify if CHW integration fits into your organizational mission. So I have been working in the CHW world for like the last 20 years. It's been my lifelong career, it seems like. And we're excited that we're finally getting to places that we started advocating for almost 20 years ago. And have really been trying to keep abreast of all the things that are happening in the state. I've worked with, over 40 organizations in our state, large organizations, to help bring CHW integration into being in their organization. Worked with Telegen and other leaders to really look at that true integration approaches. So excited to share some of that information with you today. So, love to know how many organizations on here currently employ community health workers. And if you do, what are they doing in your area? So let me see if I can pull up my chat. Okay. So if you could just put it in the chat, or if you want to unmute and share a little bit, that would be great. So, how many of you currently employ CHWs? Let me see your hands raised if you do. So I'm not seeing any hands raised. Am I missing that? So nobody on here has CHWs currently? Oh, I see one. It's Kia. Can you tell us who you're
Yeah.
with?
Hi, Tracy.
Hi.
My name is Kay. I am with Lake County. We have a digital growth initiative, the county government, and we have two digital navigators that work in the healthcare space specifically. So we have a partnership with the health department, and one of our navigators works at the Mid Lakes Health Center in Round Lake, and one of them primarily works at the Zion Health Center. And
Great.
so they are integrated with the care teams, and they're kind of a specialization of the community health worker assisting with digital literacy and patient portal signups.
Yeah, and I've learned about this program through some of the other conversations we've had, and so I love the digital literacy and the insurance, the navigation signups and those kind of things. So it's exciting. But I think again, even hearing from Kay, you can see how there are so many different things that CHWs can do in the employment. I see that some people are putting they currently don't. Others are saying we're working on that and they're going to come into our health equity teams. Some people are in the process of adding CHW. So this gives me a good idea and I appreciate that. And so Kay too, since you're probably one of the ones that has a little bit more experience in integrating, please just share things that you have to share on this topic as we go along. Hey, see if I can get it to move here. So why does this matter in Illinois? Well, we know that Illinois, just to review, right, is increasingly recognizing community health workers as essential workforces. The Medicaid care focuses on health equity, care coordination, and reducing avoidable utilization. What sustainability depends on. And so it's one thing to say, hey, we're going to pay you for doing CHW work. But we know the way that any workforce is successful is we have to think of it as a workforce sustainability. And that depends on role clarity, documentation, leadership support, and measurable outcomes. Those are four big areas as you're building out your CHW program to make sure and include. So role clarity, for example, is just a huge one. There are so many things, again, that CHWs can do that, oops, I lost my thing there, that CHWs can do that it really makes it hard sometimes for those CHWs to have true role clarity. And then there becomes a confusion, and that way, and then the whole scope of practice gets kind of disrailed, and that becomes really hard. So when we really think of healthcare transformation, it's really to reorient healthcare delivery systems in Illinois around the people and communities. So what's really happening right now in Illinois, yes, we're adding CHWs to be billable services, but this is a whole reorientation of the healthcare delivery system. This is a way we haven't been used to paying for. And really, for a long time, we've talked about this fantastic idea of let's center things around people and community, but it's going to take a process of actually making that happen. And so when we really think about these components, we really look at, different health equity initiatives that are happening across the state, how our MCOs are looking at this. And so all of this will look so different. So the whole ecosystem is changing. And that's why we really wanted to talk about how the sustainability could look and how integration does. For the organizations I've worked with, one of the biggest areas that I have seen lead to failure is not truly integrating CHWs into the process. A lot of times they sit out in a siloed space, maybe in their own little community initiative work, and that has worked well sometimes for the funding the way it is, but it really hasn't changed the community on a large scale, but it also won't work effectively to get the outcomes that will be looked at in terms of Medicaid billing. So we have to jump deeper into integration and really kind of address some of those things that sometimes we just don't want to talk about, or those elephants that are in the room. So when we think about Lake County, our local data suggests that we have high chronic disease burden, especially in Waukegan and North Chicago, that there's behavioral health access gaps, that there's maternal health disparities, that there's transportation barriers, and there's food insecurity pockets. That's probably nothing surprising to anyone on this call, but I bring those up because when you start to look at how to put CHWs into your programming, if any of these correlate very well with your mission and the work you do, these are good areas to focus on, right? Because you're going to be able to have a population that you can serve, and having a number of population allows you to have a lot of times a bigger return on investment. So also kind of crosswalking these types of data needs will help you to identify where should we start to focus. That's always one of the big questions when I meet with groups first. They say, Tracy, but where do we start? There's so much CHWs can do. I always say, go back to data. Let's start at the data level. And so Ava and Rachel and their team and all of us have really looked at this and said, hey, these are key areas that local data suggests that CHW programming initiatives would make a huge change and improvement in the health of the residents of Lake County. We also know there's that linguistic diversity. So any way that you can bring in that Spanish speaking, that immigrant and refugee populations into your programming is a good way to do this. So these are key data pieces that really can help you guide when you're having conversations or looking at where do you want to put your CHWs in the work they do. So some great, Lake County resources to utilize is that Lake County Health Department, the Live Well Lake County, and really taking a look at those social drivers of health. So even though Lake County is considered one of the healthiest counties in the state, it faces these distinct burdens. For those organizations who are on here, is there one or two of these key areas that speaks to you and what the mission of your organization is that yes, this is where we're thinking of placing CHWs or putting in their scope of practice. Does anyone want to come off mute and share that? Or if you have other things that you're thinking of, please share, because it's always great when we get a group together and someone shares something and another organization says, wow, that's an area we could do too. Anyone have anything you want to share or thoughts?
Yeah, so we do a lot of work in schools. I'm CYN Counseling Center. We do a lot of work in schools, and oftentimes our social workers will come across students that are facing these issues, whether it's disease, access to healthcare, transportation, food insecurity, you name it. And our social workers are so busy, our therapists are so busy seeing kids providing mental health services. It would be great to have somebody that could come in and work with the family to guide them to get them, connected with services. So
Yeah,
that's what I
Gail.
was thinking, like a community health worker would be perfect for that.
Yeah, that's a perfect example. So we have set up some really positive programming in schools that have CHWs involved. And so again, the biggest thing there is to select that population, right? So is it those ones who have some SDOH needs? Is it students, and you may even be able to define that a little bit more, maybe students who have those social drivers of health who also have X amount of truancy days or X amount of absentee days, right? So that you can start to narrow down and have a key place to start. So I always say choose a large population and then subpopulations underneath that, right? Because we know for those different tiers. So when we think about school districts and working with them, we often have children placed in different tiers of need, right? And learning needs. And so selecting your tier is going to be critical in that space. That's also going to help you get to the data that will help guide you in selection of that population, Gail. So I would be happy to talk a little bit more about that. I have a few different examples of how schools have set up some CHW programs based upon data and population needs and how to take that to your school board and all those kind of things that that need to happen. And sometimes those CHWs are employed within the school district. Sometimes they're employed within a community-based organization. I have one place that employs them at the healthcare center, and then the CHWs work exclusively in the schools because that made that connection to get them into medical care faster. So again, Gail, there's lots of things we can sit down and think about. So as you look at the populations, write down kind of descriptive natures, and then we can problem solve to build the best program that helps you to meet either the children with the greatest needs that you want to. So that's a great example. I'm glad you're doing that, Gail. That's wonderful. Anyone else have anything else to share on what you're thinking?
Hi, yes, this is Aurora Santos from the Highwood Library and Community Center in Highwood. The library has hired or employed a great team of of
Community health workers?
CHWs.
Yeah,
Sorry,
you're fine.
just thinking about the word. But yes, we have had CHWs for at least 5 years, and they have worked with the community in all of these areas. We go from education, therapy, and the work that they do is it is in all areas really. They work as a liaison and they connect participants to different resources. We now have a team of digital navigators, and we are also connecting families with different resources and helping them with navigating online. So yeah.
Excellent. Good. Anyone else have anything you want to share, kind of how that connects to some of this data or what you're seeing?
There's a few comments in the chat as well.
Okay. Let me pull up my chat. I had closed it for a sec. Maybe. We were having problems with my computer earlier, weren't we?
Do you want me to
I
share
got it
the
here.
chat? You
Yeah,
got it?
I've got it here.
Okay.
So we're coming from the educational training side of things and really focused on making sure our Spanish speaking community members are served. And so this is excellent, Kara. Yes, we have seen that sometimes a gap, right, in the educational and the training side. And so this is going to be really critical, especially when we look at the linguistic diversity that exists in Lake County. Um, Kay shares it's been essential to hire staff who are from or live in the community where they're serving. We've also ramped up our hiring of bilingual English and Spanish speaking folks. Excellent. And that first point, Kay, is really critical. Um, the training time that's required to and the connection time that's required is shortened so much whenever you hire someone from that community and or has that lived experience. As far as transportation, there's a major barrier across the county. We have our team members travel to public spaces where they can meet residents close to where they live if they cannot attend sessions at our pre-designated service locations. So yes, Kay, this is going to be a big thing that can happen, we hope, with what is the proposed rules is for billing, because that's one of the things we have to think about in terms of billing is like, where can services be provided? In the proposed rules for CHWs, a CHW can provide a service at an area of choice of the client. So that will work. Sometimes it doesn't because it says it has to be done at the FQHC or in the clinic or in a hospital. This proposed rules gives us a very broad space of where you can bill for services from. So that's an important thing to think of too as you build this out and say, where can services be provided? So we're anticipating that in the proposed rules, it will be very broad and will allow for all of these different scenarios we're talking about, but we'll closely monitor that. The one exception is if you work at a federally qualified healthcare system. There is a form that you fill out that you have to have pre-approved federally that says where you will provide services at. You have to follow whatever you've submitted for your FQHC in terms of service locations that you can provide services at, we believe. We're still trying to clarify all that point, but that would be the only exception to being able to provide it like to at public spaces if you're a FQHC who does not have a site that has been approved for billing. Guadalupe, I see that you said awareness around correlation between medical and mental health issues very much. So it fits in to this behavioral health access gap, right? And yes, they're so much easier to trust. So great comments. Thank you so much. So it sounds like you guys are taking the right steps by using data to help guide you in this process. So when we think about the core competencies, I think was it Guadalupe or someone already said, hey, or Kay said trust is important, right? That's so much easier to trust. Well, this is really those core competencies. And so this is where hiring is so essential. As you're looking at integration, making sure that you're hiring correctly. Now, sometimes you have to change your job descriptions or your hiring process to allow you to do this. But we want to look at for CHWs who have the ability to have trust in their community. So typically that's someone who comes from the community or has similar experience. A lot of times these folks who are CHWs are already doing this work voluntarily. So this is where identifying those folks and talking to them and saying, hey, would you like a role as a CHW that is paid? Those are your best recruits a lot of times. They're fantastic recruits. So don't be afraid of doing that. But what we find sometimes is maybe some of our organizations have set standards that those folks who have the most trust can't be hired, don't meet the hiring requirements that our organization often requires. So I worked for a university, and when I first hired CHWs 15 years ago, they required a bachelor's. It took me 5 years to get rid of that bachelor's requirement. And part of that was because of state job titles and university job titles, and where we had to place them in there wasn't a community health worker job title. So I had to, again, go to the state, work through all this process to get a job title that allowed for someone to be hired that met these competencies, but didn't have to have a bachelor's degree. So one of the things I encourage you to do if you're looking at starting a CHW program is to look at what job descriptions or job titles you have available to you, either within your organization or if you're, if you have to follow state hiring requirements or university requiring hires or FQHC hires. We all have different policies we have to follow in the types of jobs we can post and what those requirements are. So when Rachel and I look at a lot of job descriptions, we often look at the required section. And often what is always loved to be highlighted so much in those required sections is like the associate's or bachelor's degree, right? 5 years of paid experience. You know, we see things in there and you'll see us send something back and say, really, is this what a CHW needs, right? So that's where we get a lot of questions at sometimes is like, do they really need to have had paid work experience, or can that be volunteer work experience? If you need letters of recommendation, can those letters of recommendation come from a clergy member, or can it come from a community member versus a professional that had hired them in the past, right? So think about and look at those required segments of your job descriptions. And does that really get you to the trust component that you want to measure in who you're getting to apply? I find a lot of people who are wanting to do CHW or who are doing CHW often tell me, but I don't qualify. I'm not going to apply for this job. And that's because a lot of times those required components, people without formal education, a lot of times will not even, like me, if I see something and maybe I don't quite meet something that's on the required piece, I can work through that, right? I'm still going to apply. What we often see is there's a hesitancy to apply if they don't meet everything exactly as it's written. So think about that carefully. And this is one of the things that Rachel and Ava and the team that we're doing. We can look at your job descriptions you have and give you feedback on those job descriptions, because the true part of integration to get started and to do it right is to hire the right person, just as someone said in the chat. So really think about those job descriptions. Do they get to these core competencies in the job description? The best application process I have ever used for CHW positions is I have listed these out and I say, tell me, how do you say that you meet these things, right? I didn't care about their education. I didn't care about other things. I really wanted to know, how do you build trust? Give me a 30-word sentence about it, right? Tell me that. It can be in bullets. I don't even require full sentences from people who are sometimes applying, just because I don't want to put different things, barriers in place. Or give me a picture that maybe you took when you were out in the community. So I got really creative to try to get the right hires in place. I always say you can train core competencies of such as documentation, of some of those basic things, but I can't train your heart and your head a lot of times. And so that's what I want to capture in those job descriptions and those, job opening calls. We have to remember that CHWs are non-clinical. And this is really critical when we're thinking about billing purposes. So for billing purposes, we anticipate, and for CHW certification in the state, we anticipate that someone will either have to have a GED or a high school diploma. So that could be something that you could put on a requirement, right? Because if you're going to bill, you need to have that as a piece of that for them to be able to bill and be certified. We also know that they're going to have to complete a core CHW training. Now, what that exactly looks like, we don't have all those details, but those are two things that you can have in your requirements, because everybody's going to have to meet those, right? They have to have GED or high school diploma probably, and complete a core training. Now, you could complete a core training within X amount of hire time, but what you need to know is you cannot bill probably for them until they complete the certification training. So that makes a difference for many organizations as you start to think about your return on investment and your upfront cost. So you could either require someone to come in with that training already, or you could say that within the first, 4 months of being hired, you would have to complete a CHW training program. But CHWs are non-clinical. So when you look at their job descriptions that you're writing, be very careful not to put clinical roles into that CHW job description scope. That is not something that will be allowed to be billable. And they should complement, not replace your licensed staff. So Gail, as you were saying, your social workers, right? This is not about replacing social workers. This is about complementing them. So your social workers spend a lot of time setting up transportation appointments, doing all these things, right? And not being able to do some of the nuances, the skills they've been taught as social workers. And so this is where that's a complement and not a replacement. Now, also, Gail, for you and others on the call, if you have social workers, we do find that there is a lot of discussion going on about how do we make this jive, right? How do we make sure it integrates well and nobody becomes defensive or upset about it? We just on June last Friday, we did a social worker CHW integration lunch and learn. So that will be available on IPHA's website for lunch and learns as a recorded webinar for you. We'll also get that to Rachel and Ava when that recording comes out, and we'll share that out because we hear that question a lot in Lake County too. There also is a social worker CHW collaborative group nationally that is in place. And so if you have an interest in potentially joining that, that group is really having conversations about how do we create a national approach to true integration of social workers and CHWs. And so if you have an interest in joining that, if you let me know, then I'll make some connections and see if we can get you to become a member of that. But there's all these different things going on about how do we complement and not replace. And this is going to be critical for you as you write your scope of practice for what your CHWs will be doing at your location. So when we think about CHWs, we think about CHWs as coaching, navigating, doing outreach, and social support. When we think of clinical staff, we think about them in terms of diagnosis, treatment planning, clinical assessments, and medication management. So if you kind of stick to those 4 areas that I have there in your job description, that will really help you distinguish your CHW scope of practice so it's non-clinical in nature. Okay. Any questions about that? This is one of the bigger areas that we have had a lot of questions over the last few years because there has been a request for CHWs to be able to take blood pressures, right? To put medications into med planning containers. Those all go into clinical skills. And so we have to be very careful in that. We are clarifying the point, though, with HFS, if a CHW is seeing a client and they need to report their blood pressure findings and they've taken them themselves, the client has self-taken their blood pressure findings, can the CHW help them enter that information into their health chart, right? Or make a call to the doctor and say, hey, here's a blood pressure of our client you haven't heard. Jimmy, we're trying to clarify that because that is one of those slippery slopes between clinical and non-clinical. Our arguments is that they are not diagnosing, they're just reporting back, right? They're giving coaching of how to get that information back to the provider. So we will continually let you know those kind of things. But if you have a question about if something clinical or non-clinical, that's something you can easily reach out to us and we'll get you some insight. And if we don't know, we will ask HFS that question and try to get clarification for you. Any questions about this clinical, non-clinical? And because this is really critical as you're working on your job descriptions and your scope of practice, and as you're also taking the CHW role and talking to your other providers and staffing in your work area, you want them to understand that CHWs are non-clinical in nature. All right. So again, some scope considerations for CHWs in Illinois as we think about it. Well, the Illinois CHW certification environment is changing drastically, right? We're moving into some Medicaid expectations. What are some supervision requirements and what are some documentation standards when we think about this? So for Medicaid reimbursement to happen, you have to document in certain ways. And we're waiting for all of those recommendations to come out and what that has to look like. And once we have a final of what documentation pieces have to be included, we will share that back out with all of you. We're waiting for that from HFS. We do know that that client is going to have to be an active Medicaid patient, so you're going to have to be able to document their Medicaid number. You'll need first and last name. You'll need the location of service. You'll need the amount of time you worked with the client. You'll need how did you meet medical necessity and what service did you provide. So you'll need those basics for sure. So when you think about this, you'll want to start mapping those out because you'll want to be able to help your CHW know exactly what they should document. There's one thing I always say about documentation. If you're used to working with nurses, social workers, and stuff, we've been taught from day one of when I was an infant, I feel like, how to document, right? It's been told if you didn't document, it wasn't done. And you document using SOAP or you do all this stuff we learn about documentation. And I think Rachel talked about some of this last time. But remember, CHWs a lot of times are coming from a place, this is nothing they've ever been, you know, taught about or shown or had to experience it. So we have to put, I would say, of all your positions you're hiring that you would have Medicaid reimbursement for, I really encourage you to think about how to onboard carefully what documentation standards you want at your organization. This could be one of the more dangerous areas that could lead to an audit or any fraud findings. So we really want to work carefully with you and we want you to put some good time into thinking about those documentation standards related to CHW services. Yeah, Rachel?
Right. We will be offering a webinar on that. So don't worry,
Yeah.
we're not going to just leave
Yeah.
you to your own devices. We will be providing you with some of those step-by-steps.
So then think about too, like your specific sites, what kind of things is going to be specific to your site so we can help you figure out how to document that. So yeah, we've got a whole documentation webinar series coming up because this is so critical. Supervision requirements. So CHWs have to have an order or a recommendation to be able to provide services. Now that recommendation can come from a few different people. It could come from a physician, come from a PA, a nurse practitioner, a dentist, our social work, and across the gamut for social workers, LCPCs, LCSWs, etc. But that's not always the supervision that I'm thinking of. So that recommendation is important. But where we see CHW programs fall off is because they don't have someone at their site that supervises them directly. They're an add-on. So maybe, you've got someone who's supervising your social workers, and that's their whole focus. They've always done that. And you say, oh, by the way, I've got 2 new CHWs coming in. I'm going to add them underneath you without really understanding how to supervise CHWs. CHWs work a little differently, have a little different approach. And so understanding that is really critical for supervisors. So we are going to be working on for Lake County a whole program to help support supervisors, a potential training that will be offered, plus a network of support and learning for those supervisors, because this is a really essential, critical role. I read one study that talked about the success of CHW integration, and they said that 68% of programs that are not successful did not train their supervisors or help them supervise accurately. So this is, again, one of those big things we really want to support you all, and I cannot highlight that enough. So I saw that Gail asked about sample job descriptions. Yes, we have a tremendous amount of sample job descriptions. Rachel and Ava, have we made that? They're sitting in one folder that we partnered with IPHCA, which is a partner with us. We created a toolkit site for CHWs with that type of stuff in it, with job description stuff. We're in the process of transferring that all over into the Help Guide Thrive Operations Hub. And you all will have access to all of those types of things, but we could probably pull a few of those job descriptions and send them out to everyone who's on this call today. Is that okay, Rachel and Ava?
Yeah, I think what we'll do, like I keep talking about this Lake County page where you'll be able to access these recordings. We'll also make sure as we're developing it, we include a link for these types of things as well. So the wheels are all turning as we're pulling this together.
Yes, that's a great question. We will
Happening
do
as
that.
we speak.
Yes. And but again, too, if you have a job description that your agency is asking you to work from and you want to send it to us, we are glad to look at it. and give you feedback. So some appropriate CHW activities include appointment reminders, SDOH screenings, resource referrals, health coaching, health visit support. Non-clinical activities are clinical assessments. Now, CHWs can do assessments who that are not required to have a license to complete. So PHQ-9s can be done by CHWs because those don't require a license, right? Health literacy screenings could be done. Fall risk assessments could be done. None of those require licensures to complete. Now, if I'm going to do a more detailed behavioral health assessment, that requires a licensure, CHWs could not do that. So what I always tell you to do is list out the different assessments maybe you'd want your CHWs to do. And then you need to sit down and look at, is there a requirement for a licensure for that? If not, your CHW should be able to do that. I see a question in here about, do you ever have problems with CHWs acting as clinicians, giving advice, etc.? And so, Gail, I think that is a very good question and something that is very possible and I have seen, right? And this is where those programs that fail or struggle is because that happens. And that often happens because you don't have good supervision and onboarding. So, that's why I bring that up very early on, right? Is that supervision skill, that person acting as a supervisor really needs to be watching for this because it's easy to fall into this potential, right? Because the clients trust you so much, they start asking all these questions and they don't even realize sometimes that they're giving you a diagnosis or more direction kind of that a clinician should be giving. So really setting up some protection in your supervision's approach to that is really critical. And we can actually probably add that. We can do a little webinar on some of that type of stuff too, Rachel, because that's a really specific training approach and protection approach to take. Yeah, Rachel.
So I was actually on a call earlier today with another organization in Lake County that does similar work to you, Gail. I almost think it might make sense at some point to convene all of the groups that fall under that same, that do similar work to you, because they have the same exact interests as you and kind of said, hey, I can see how a community health worker could help us, but like getting us all together and brainstorming what that could look like and then developing the types of things that you're talking about, but all of you doing it together.
Could actually create some, we've done this in other communities, some shared onboarding pieces together. So you each don't have to create your own onboarding. We can create kind of an onboarding that addresses this. Like, does someone ask you, well, do you think that I, have rheumatoid arthritis, right? Well, how should a CHW respond to that? That's a legit conversation and case scenarios to practice with. So I think we could really pull everybody together, create some of those kind of potential pieces that could help with onboarding with that, Gail. But yeah, no, that's a true problem that can occur. And that's where these kind of things through documentation, supervision, and training on what's allowed and what the scope is and reinforcing that job description is really critical. So let's look briefly at billable versus non-billable activities. And I've already started to talk about this, but you're going to hear me reinforce this, because this is so critical as you start to think about integrating your CHWs, or if you have CHWs, can they continue as they are? Or do you need to make some adjustments? So a CHW helping a Medicaid patient discharge from a medical center, connect to transportation and primary care follow-up. So a potentially billable service related to that will be care coordination, an SDOH assessment where they assess that, yes, they need transportation assistance, a follow-up navigation. So you called a transportation company to get that set up, and then you follow up and make sure that actually occurred, right? And transitional care support. So those would be things that could be potentially billable. And so what we would have to do, what you should do in your organization, is define what those terms mean for each of your CHWs. If you are in the school-based setting, for example, let's say, an SDOH assessment could be as simple as doing that, those 4 or 5 basic SDOH, social drivers of health assessments. It could be doing an ACE screening. It could be different things, but giving them exact examples of what's within their scope will help allow you to keep that scope of practice in place. What do we mean by follow-up navigation? That may mean that and we're waiting on rules yet from Medicaid, whether it has to be face-to-face or can it be telephonic, or can they do this without the client even involved? Can they follow up with the doctor and say, hey, Johnny had an appointment. Was Johnny able to make it in today? Or do they have to call Johnny directly and ask, did you make that appointment? Or do they have to be seeing Johnny face to face to ask him that question? We do not know yet. So in a school setting, they could bill if they went to the school classroom, are they met with the student face one-on-one? But we're trying to see about those other nuances around what that interaction has to look like. So we'll let you know that. But taking and defining these potential billable activities specific to the population and the activities you want your CHWs to do is very critical for your onboarding and then also for their guidance. Now, it is not anticipated to be billable to do community events, to do general outreach, to do administrative scheduling only, or to attend staff meetings. So, and the reason I bring these up is because you need to start to think about these as you build your return on investment, because these will be non-billable hours of your CHW work. And so you have taken all of these to say, so maybe only 60% of my CHW's time actually would be sustained by Medicaid payments. The other 40%, we have to look and see how we're going to support them. So again, asking within your mission of your organization, do your CHW roles support billing services? Does it provide preventable care? Does it do health navigation? Does it do health education and coaching? Does it do resource connection and patient advocacy? Like I said, we still have some gray areas out there. We're trying to find out, will helping to refill a med box be allowable? If they're not, prescribing it, they're not doing anything besides what the label says, or even if they're sitting with the client's putting those in, right, according to the label, is that going to be allowable? Checking a med box if it's filled. Documenting a clinical finding a patient self-identified, or helping a patient at a grocery store read food labels. So we know that the HFS has said helping a client shop for groceries is not a reimbursable role. But if the client asks you, and I've had this happen many times to me when I've been talking to them about diabetic diets, they say, Tracy, I don't know how to read the food labels in the store. It gets confusing on which aisles to pick, right? Because I can often do a lot of training with my clients to help them know, don't go down this aisle, right? Skip this aisle. This aisle is not going to meet your diet needs, right? So I've often went to the grocery store with them to teach them that. That's education. But will HFS see that it was documented as being done in a grocery store and deny it? So these are the kind of things that we're constantly sending to HFS to give them ideas of things they need to be thinking about. So as you're looking at integrating CHWs into your space, and if you think of a question you would like us to pose to HFS, like these gray areas, please send them to us. This is where an open line with HFS is really critical as they build out this proposed rule. So again, I think I talked a lot about this, common job description gaps. Sometimes I will tell you, when I look at job descriptions, I see them having the CHWs function as medical assistants. This is not going to be able to pass an audit because it's going to be more clinical in nature. They have undefined caseloads. This is a big thing to think about. I made this error when I first started out about 15 years ago and hired a CHW. We didn't have a clue what we were doing, how we were going to find clients or anything. And funding started in 2 weeks that I received. So it's like, okay, I'm going to get a CHW and we'll figure it out from there. And it was so crazy how fast clients were coming in, right? And, we didn't have all the criteria set yet. So really thinking about what is a good caseload for a CHW. You'll see differences in the literature. And again, this sometimes depends on the complexity of the client. So it could be anywhere from, and it depends if they do single person or they're doing family-oriented care, right? So I sometimes have seen as little as 10 families as a case for a client. And I have seen up to 200, well, really, I've seen up to 2,000 clients for a case. Those typically were our MCOs during the Obama period of time when the whole CHW piece came into the MCOs. That is way too many. We usually say somewhere between 30 and 50 clients is a number that a CHW can have effectiveness with. But that really has to depend on the complexity of the client and how, across the continuum of services, those CHWs provide services. But you really need to think about that caseload and how you're going to define that and what happens when they reach that caseload, right? So I would have providers who would say to me, well, you're working with Dr. X's clients. I want this client to come in. And, I'd have to say, we've reached our caseload. We can put them on a waiting list, which was very hard. And it's very hard for the CHWs because, they're there because of their heart, right? And so this is something, again, your supervisors often have to continually check and remind them about. No workflow integration. No reimbursement language, and missing documentation. So when we think about documentation, for example, a lot of times people will want to say, assist patients as needed. I can tell you that is going to fail an audit. It's probably going to get you denied reimbursement or a fine to pay reimbursement back if there's an audit from Medicaid. Instead, really thinking, provide culturally responsive care coordination, resource linkage, and health education aligned with Medicaid care coordination requirements. That type of language is going to be really critical for us to think about. Now, sometimes you can do that kind of as drop-down menus, as different clicks, but really having a more description around it. And those terms of cultural is going to be important, resource linkage, and then you might even put specifically link them to food at food pantry, right? So you can start to kind of see how to expand this. With this type of practice, we really have to be very careful just because of the potential audit and fraud findings that we have seen across the nation. So we're going to spend a lot of time on documentation, but just to get you to start to think about that. I saw that there was a couple questions in here. Can you ask HFS if there are client scenarios that would be recognized as higher risk or more intensive that would then affect caseload totals? So right now, HFS is not distinguishing higher risk or intensity of clients. They are really just trying to get a CHW reimbursement on the books. Over the next 5 years or, next 5 years of work, when I think about what that work looks like, we really have been having conversations about tiering out CHW's assignments and cases with different potential reimbursement rates and requiring CHWs to have, more training in certain areas. So let's say you've got a CHW who's working in a maternal child health area. Maybe they take a specific training around that, and maybe they'll be able to bill at a different rate. That is not where HFS is right now at all, but that is on the discussion table for the future. So yes, exactly what you've got here is a lot of the things that we're pulling in to say, can we do this in the next go round? Great question. So workflow and caseload design, you can look at these referral pathways, team integration, warm handoffs, documentation systems, caseload balancing. And so just put kind of an example in here that you can look at, but really writing those workflows out is going to be so critical for CHWs. Because again, think about it. As a nurse, I've been trained in a clinical setting and often thrown into different workflows, right? And I've figured that out after I went to 12 years of different schooling. I knew workflows, right? Where I fit in, where I didn't sometimes. CHWs aren't going to often come in with that ability. So having that as expressed as clearly as possible is going to be critical for them. So job description, audits, again, I'm coming back to job descriptions. This is a huge place to start for integration. Which duties support reimbursement, which duties drift into clinical scope, and what documentation is missing. This is what I really encourage you to look at. So, if Maria spends 40% of her time scheduling appointments and entering demographic data, is that sustainable if you are going to require on billing completely? No, because entering demographic data is not going to more than likely be a reimbursable time. Now, scheduling appointments could be depending on what she has to do to navigate that. But if she is just scheduling appointments generically, that means that 40% of her time here will probably not be billable services. And really, is she working at the top of her license? Do you really need a CHW to be doing time scheduling appointments and entering demographic data? Same thing, Gail, what you see, and I don't mean to keep coming back to you, Gail, but it's a perfect example. Your social workers, right? Like you said, they're not working at the top of their license right now, right? The top of their certification right now, because everything else is pulling them that has to be done. And so, and as burnout we see in other disciplines, we have the same risk for CHW. So if we don't integrate carefully and look at this and make sure they're working at the top of their license or top of their certificate, we could create more burnout than we do advancement. So, this is a tool that part of this, Rachel and Ava, you'll provide the CHW integration toolkit. We have a toolkit that's been developed. But when you think about this, it walks through scope clarity, talks about supervision structure, talks about documentation standards, billable activity mapping, caseload expectations, and equity-centered practice. So when you look at this toolkit that we'll share out with you, you can go through those different sections and look at how are you doing in those areas. What areas do you need to focus on? You may look at some of them, you say, hey, we got that down. You may look at others and say, oh, we're just starting out here. And it's fine to have different places in each one. What we can use this time together as over the next few months is to really help you build in those areas that you have gaps. So last concept here is to look at your missions, governance, and organizational readiness. Does a CHW really fit into your organizational mission? Or let me say it differently. Does a CHW who is billing for services fit into your organizational mission? Because there are some times that it does not meet what your mission is. And that is perfectly fine. Not all CHWs have to bill for their services. And if you're not going to bill for services, they also don't have to go through certification. So, but again, if you don't have leadership alignment, we see a lot of failure points. Sometimes grant only thinking, and we're going to see grants change, that could become a failure point in the future. So you need to have some more global conversations on that with your leadership. It's okay though, as long as they understand this is a risk. No strategic ownership. If no one in your organization is kind of the leader, if there isn't that supervisor, if their leadership doesn't buy in, it's very hard to have a truly integrated, successful CHW program. If you're not tracking outcomes, that doesn't help. You're going to need outcomes to continue to grow, to see if you're on the right direction, and to continue to help grow. And role confusion. Again, this comes back to that question Gail asked earlier. We see role confusion that can occur if we don't have good things in place. So this is where we need to have executive support, good board engagement, good operational alignment, and a good funding strategy. So these are all things as an organization we can help you to work on. And so do we have outcome tracking tools? So you'll see that in our integration toolkit that we will share with you, there is a section called outcome measures, or ways to measure those outcomes and to build sustainability. So we can provide that with you too. And we are continuing to grow those outcome tracking tools. But I also have a lot of specific ones related to topics, places that you may be specifically integrating into. So again, if you reach out to us directly and say, here's where we're looking at, I can share some of that literature and some of those different documentation and processes of measurements with you. So meeting with the organizational mission, like I said, does your mission look at health equity, community engagement, reducing disparities, whole person care, value-based care readiness? In Lake County, for example, if you're reducing avoidable hospital use among high Medicaid populations through trusted community outreach, a CHW that is billing Medicaid is a perfect integration into your organization's mission. Again, there is a readiness assessment tool within that that we're going to share out with you. And it makes you look at Do we have a leadership champion? Do you have defined workflows? Do you have tracking capacity? Do you have supervision models, community partnerships, and sustainable funding plans? And each one of those are broken down into a lot more details in there. Board and leadership engagement. Your leadership needs to hear. They respond to returns on investment, reduced hospitalizations, equity outcomes, patient engagement, community trust. So look at what does your board like to hear about when you're bringing a new topic or concept to them. We know each board has a little different focus sometimes, and you have different players on your boards that want to hear one piece versus another piece. And so kind of measure out your boards. I always say you can stress that CHWs reduce barriers before they become crises, and CHWs improve engagement in populations that are often hard to connect with. I have tons of these little quotes of little sayings that you can fit into your board presentations. So if you want to reach out or if you need help with that, please let us know. Sometimes it's that right catch line to start the conversation, which is so critical. There's a lot of sustainability planning that you can start to do, from Medicaid reimbursement to managed care to value-based to grants to hospital community benefits alignment. Specifically, we are increasing Medicaid and Medicare alignment. And there's some 1115 waiver, the care coordination opportunities, and some different health equity initiatives. So there is a lot of different ways that you can braid funding to sustain things. So we are almost out of time, right? Because we go to 2. So one of the things that you can do, and again, when you get the toolkit that we have, you can look at it and say, how do I score in workforce readiness? How do I score in leadership support? How do I score in my data infrastructure? Where's my community partnerships? Where's my financial sustainability? And ask, what is your organization's biggest barrier? We need to start and think about your biggest barrier. But we also need to start with your biggest champion too at the same time, so we can come together at that point. So look at those things. Start planning your actions. What are your next 3 actions, right? Will it be to review your job descriptions? Will it be to identify your target population? Will it be to present a sustainable plan to leadership? Write those 3 next actions out with a timeline. And again, that's something our team is here. We can help you to think about those, to refine those, and to help you put products together to take out. So key takeaway, CHWs are not clinical substitutes. There are clear workflows that they do improve sustainability. Population targeting improves outcomes. That has been shown time and time again in evidence. Leadership alignment is essential, and equity-centered models drive that long-term impact. So I'm going to stop there. I think I answered most of the questions that were coming up in the chat as we went along, but in case there's others, please let me know. Trying to see here. I think it's been essential to hire staff. Oops, I get down to the other.
I think you've got all the
I
questions.
think we got them all.
Yeah.
So thank you all for joining. I hope this was helpful. Again, we'll send out the toolkit that has a lot of this detail information in it. And as you look at it, you are always welcome to send us particular questions, because the other thing we're trying to do, just like Rachel was saying earlier, is we identify 4 or 5 of you that are having similar needs or similar programs that you're setting up. We want to pull you together so you're not recreating, but then you can create something that is complementary in nature across the board. All right, it is 2:01. I appreciate everybody's time. I'm so excited about the great work that you are doing. And I want to make sure that, do we have the Highwood Library? We do, on our email list, right? Okay.
Yep.
Because I know
Yeah,
I
no,
was
they've been doing great work. So
the
we've been in touch.
libraries were fantastic when we built out CHW programs for pandemic work. So again, we have tons of ways to measure that work that you're doing there. So please let us know. But you guys are all I just can't wait to see what happens in Lake County as things roll out. So thank you.
Thank you, Trey, for providing
Bye-bye.
your expertise in this area. So we appreciate it. All right.
Bye-bye.
Bye. Thank you.